So welcome. Welcome to the ERA EDTA CKJ Journal Club. It's an e-seminar which takes place on the last Thursday of the month at 1700 Central European Time, which is 4 o'clock in the afternoon here in Oxford. Each e-seminar picks out a topic from a recent CKJ original research or key review article, and the author or authors will introduce their work, and there will be expert panelists. It will be moderated by the CKJ editor-in-chief, Professor Alberto Ortiz, or myself. I'm Will Herrington. I'm an Oxford-based nephrologist and epidemiologist, and the discussion will last up to an hour. It will be fairly informal, but we will encourage live and hopefully lively questions from you, the listeners. Please type them into the Zoom Q&A box, and we will answer as many as we can. And the meeting is recorded and available on various video platforms afterwards, so keep an eye on social media for links. Now, today is our 8th CKJ e-seminar, and we're actually returning to the topic of our very first, when we introduced an observational study looking at potential for cardiac benefits of cycling whilst on dialysis. Now, this time we've got randomized data. It's a particular passion of mine alongside cycling. And we're really spoiled because we're going to hear results not only of one trial, but 2 cycling trials from their respective chief investigators in the same e-seminar. The first trial will be presented by Sharlene Greenwood from King's College London, who led the pedal trial, and the trial's baseline paper was published in CKJ last year. So welcome, Sharlene. Yeah. We also have a returning Jedi of these e-seminars and a Jedi of exercise on dialysis. From Professor James Burton, who supported our first e-seminar, and he led on the Cycle HD trial. He works from Leicester on their dialysis program and their exercise rehabilitation. Thank you, James.
Thanks, Will.
And then we've got 2 experts this week. We've got Professor Ken Wilund from the Department of Kinesiology and Community Health at the University of Illinois, and is founder of the Global Renal Exercise Working Group. Thank you for joining, Ken.
Thank you.
And Dr. Clara Bohm, who's in Winnipeg, Canada, who's an assistant professor and clinical researcher at the University of Manitoba. I think it's fair to say you've got the same interests as our speakers and our other experts. So welcome to you as well.
Hi.
We have a jam-packed tour this afternoon, so I think we should sprint straight on to Sharlene's pedal trial presentation and hand over to you.
Okay, so hopefully you can see my slides okay there. So thanks very much, Will, and thank you to everybody for the opportunity to come and talk to you today. This is just my disclosure slide, so no disclosures apart from that I'm the president of the UK Kidney Association. So I'm here today on behalf of the pedal trial study team to talk about the results of the pedal trial. And to start off with, I just wanted to touch on why we wanted to do pedal, why we wanted to actually do the trial. And really, we have seen an improvement in dialysis techniques and management of coexisting disease that has made hemodialysis more tolerable, and many new patients can anticipate a longer life expectancy, although this is not always with an associated good quality of life. And in particular, patients report multiple symptoms that impact upon the physical component of health-related quality of life. Evidence from several systematic reviews indicates that a range of exercise training interventions show potential to improve exercise capacity and physical function in patients with dialysis-dependent chronic kidney disease. And of particular interest are studies that have investigated intradialytic exercise, as the environment of unit-based hemodialysis provides a platform to implement exercise rehab programs during what is routine thrice weekly 4-hour-long hemodialysis sessions. However, very few dialysis units to date have chosen to implement this type of rehab, and a barrier to implementation has been a lack of high quality, adequately powered randomized controlled trials. which have included both patient-reported outcomes, health economics, as well as the reporting of potential harms. And so the PEDAL trial was commissioned by the National Institute for Health Research to evaluate whether intradialytic exercise training was able to improve health-related quality of life in patients with chronic kidney disease on haemodialysis therapy. So we conducted a pragmatic, prospective, randomized controlled trial in 5 regions across a total of 12 haemodialysis units in the United Kingdom. The trial recruited 335 prevalent patients receiving haemodialysis. The intervention consisted of using a modified cycle ergometer to perform aerobic exercise 3 times per week during the first 2 hours of haemodialysis over a 6-month period. Twice a week, participants were also encouraged to complete lower extremity muscle conditioning exercises using either ankle weights or TheraBands. And the exercise program was delivered and supervised by physiotherapy assistants. The primary outcome for the study was the change in kidney disease quality of life physical component score. It was the SF 1.3 version of the KDQOL, and this was between baseline and 6 months. Just to mention that the baseline demographic data of the PEDAL trial cohort broadly aligned with what is the real-world dialysis population in the UK, and that was as detailed by the latest data from the UK Renal Registry. However, the study did have a larger proportion of Black African and Black Caribbean participants and a lesser proportion of white participants. So when looking at the results for the primary outcome, the mean difference in the change in the physical component score from baseline to 6 months between the exercise and control group was 2.4 arbitrary units and was not statistically significant. Alongside this, there was no statistically significant improvements in any of the other physiological outcomes, which were measured as secondary outcomes, and also no statistically significant difference in SAEs between the 2 groups. So that's just looking very crudely at the results from the trial. And what I wanted to do is to take a closer look at what the data actually means. So for the primary outcome, as I mentioned, the mean difference was 2.4 units, and it was not statistically significant. The score of 50 is the normal US healthy range score, and that's plus or minus 10 units and 1 standard deviation. So 98% of the population has a score between 30 and 70. And what you can see here is that the controls got slightly worse and the intervention patients got slightly better. So the first thing to ask here is, was PEDAL underpowered? And firstly, we could say no, because it was powered to detect a difference of 4 units, and that would only require 87 patients per group. And we had that in our final group that we analysed. And also 4 units was deemed to be clinically relevant. And we have seen even observations of increases of up to 7 units in studies like Trish Painter's study from 2000, albeit that included home and home exercise as well, and was a non-RCT design. But yes, it possibly, if you look at it in terms of minimum important clinical difference, possibly it was underpowered, because the evidence suggests that a decrease of 2 units, there is an odds ratio increase of not being able to work, of being hospitalized, and of mortality, and that this also corresponds to changes in other important outcomes after intervention, such as walking distance. So the power to detect a difference of 2 units would have required 201 patients per group. The next thing to consider was, when we look at power, was whether withdrawals were a concern. And we know that we had 234 of the 335 patients who attended a baseline visit. So when looking at withdrawals, we saw that we only actually had one adverse event that was attributable to the intervention. That was a type 1 diabetic with autonomic neuropathy who experienced severe episodes of symptomatic hypertension that were possibly exacerbated by the intervention. The other thing to note is that both participants and also physician withdrawals had a minimal impact, and so we concluded that withdrawals were not a concern. So going back to the primary outcome, you will see that 0.06 is close, and also that the confidence interval supports that there was an effect. So there must have been a good correlation. So I'm just going to take you away from the stats and explain the actual data. So for there to be a cause and effect relationship between intradialytic exercise and quality of life, there also has to be a mechanism or a mediator. And if we look at the other measures of health-related quality of life, so energy, fatigue, burden of kidney disease, the EQ5, D5L, these were all unchanged by the intervention, as was peak oxygen uptake, sit-to-stand test, gait speed, IPAC, DASI, and also the Tonetti scale. So what was it that was increasing or driving the increase in the physical component score? So the only positive effect was on role physical, and this assesses a much more general concept of how physical health impacts upon work and other activities. And this is really positively influenced by improvements of self-efficacy. Of note, physical function did not change, and physical function looks more at the ability to complete specific physical activities. So that would be like climbing a flight of stairs. And that's something which would be positively influenced by objectively measured functional capacity. So what we see as having happened in this study is that participants interacting with physiotherapy assistants possibly had an enhanced perception of their physical quality of life. And these response shifts or changes in the participants' values or their standards for measurements are quite common and well known, as are interactions which increase self-efficacy. So the reason the physical component score was raised by the 2.4 units was, in our minds, due to an experimenter effect in the study. So the story so far is that there's a meaningful increase in physical component score, but that this is likely due to an experimenter effect. So if that's the case, why didn't PEDAL increase the physical component score as much as we expected? And why didn't the mediators of physical component score increase? So exercise tolerance and physical function. So we think that this is most likely to be due to compliance and adherence. Our most commonly reported reason for non-adherence was fatigue and intercurrent medical events. And also only 42% of participants avoided a temporary cessation of 2 weeks or more during the study period. So for there to be a cause and effect relationship between intradialytic exercise and quality of life, you would expect there to be a dose-response relationship. So we conducted a pre-specified exploratory subgroup analysis using the comparison versus the control. And you can see that all three analyses were statistically significant. And this significance was driven by negative changes in patients who completed less than 30% of their prescribed sessions. But this significance was also driven by patients who completed more than 30% of sessions showing a benefit. However, there's no obvious dose response with people completing more than 50% or more than 70% having more further benefits realized. So taken together, the findings suggest that completing more than 30% of exercise sessions may confer some benefit, but the lack of a dose response prevents us from saying that it is exercise per se that increased the quality of life. So just very briefly, back to the primary outcome. So we looked at why our data possibly contrasted with the literature, but actually it doesn't. And we can see from a systematic review by Gomez-Nito, published in 2018, which shows that only progressive resistance training rather than aerobic training increased the physical component summary. So was pedal cost effective? So no, because it had no statistical benefit at group level. And just to note really that the cost per patient per year varied between 464 patients and 848, depending on whether it was a rural or an urban setting, and also with London weighting being included. Was pedal safe? So cardiovascular and all-cause mortality was not different between groups. However, we weren't also powered to detect this. So just to end off really, this is speculative and this is something that Jamie McDonald put together. So I'm going to thank Jamie for putting the slides and some of the other slides together. But just to help you predict what might happen in your haemodialysis population over a year. So you could do nothing, or you could do something, and 25% of patients will see no benefit and 75% of patients may see some benefits, and it will cost between 450 to 850 pounds per patient per year. However, would that be due to exercise per se, and whether are there better points in the CKD journey to intervene? And these are all things that possibly need to be considered. So in terms of future directions, it's important to make sure that the minimum important clinical difference is realized when doing power calculations for these types of studies. We would like to determine the effect of longer duration of using progressive resistance training, and also possibly using extra dialytics, so off dialysis types of training with this population. As always, it's important to tailor interventions and deliver them in partnership with the patient. It's really important to allow patient choice and really to target barriers such as fatigue before adding in any type of intervention. So in conclusion, the PEDAL study was a 6-month intradialytic exercise program, predominantly with aerobic training that could realistically be commissioned as part of routine care. But in this inclusive sample, we didn't see an improvement in health-related quality of life. But when looking at pre-specified subgroup analyses, we can see that a group of non-compliant patients who achieve less than 30% have a decline. And if we can achieve more than 30%, we can possibly see an improvement, but that there's no additional benefit of doing more than 50 or 70. Okay, thank you very much. And just to really acknowledge all of the patients, the PEDAL team, particularly Jamie McDonald and Pelly Kufaki, who have been very much part of doing the whole study with me and the analysis and the reporting, all of the research and physio assistants and the different trial committees.
Great, thank you, Sharlene. That was wonderful. I'm going to go ahead and get the questions started. I know we'll be monitoring the questions in the chat room as well, but just to get things going, I wanted to ask you if you thought really one of the problems might be with the study and just the way we measure quality of life in general. We've got these questionnaires, and I've always been somewhat skeptical if they really do capture quality of life in a robust way. It changes the quality of life in particular. And because I've seen this, you've seen this, anybody who's ever done interdialytic cycling or any exercise study has seen just, we've got these amazing anecdotes that, you know, in a small subset of our patients anyway that undergo exercise training, we change their lives. I mean, they get remarkably better, and they have, you know, their ability to lose weight and get on transplant lists and these incredible findings. But it's in a very kind of maybe a small percentage of the patients where that happens. So my question to you with that lead in is, do you think part of the problem is that we're just not measuring quality of life in an adequate way, or because our tools to do so are poor? Or do you really think that this is a legitimate finding where we're just not doing enough to improve quality of life in most of the patients?
I think it's interesting, and I think you could look at it in two ways. I think that we very rarely see, as you say, an improvement in quality of life using the tools that we do use in the types of studies that we do. And I think it's possibly because there's so much else going on with this patient group that we don't always pick up, you know, the intervention per se with that. But I, you know, picking up on your anecdotes of patients that we can see this has really transformed their lives. I think you can see in the subgroup analyses that, you know, those patients possibly without the really severe complications who choose to, you know, to take part and to commit and do what's prescribed, I think, you know, there is a possibility that they can see those benefits. But, you know, I think what we can see from the results from PEDAL is that if you apply it across a general hemodialysis population and try and include everybody and get them doing cycling, it's maybe not for everybody. And actually, we probably need to have that patient choice there, and also just other options which may be more suitable for say frailer patients or patients who just choose that they don't want to cycle.
I couldn't agree more. Yeah.
Sharlene, I have a couple follow-up questions for that topic. And one is just, what was the vintage, the hemodialysis vintage of your patient population, your participants? Were they, had they been on dialysis a very long time or a short time?
I can't, do you know what? I can't tell you it off the top of my head right at this second, but it was, we did initially want to do this in new hemodialysis patients. And actually our patient advisory group decided that that was not the time to do it and that it should be done in a much more inclusive group of patients. So we had quite a wide ranging dialysis vintage. But I'm not sure is that what the average was.
Yeah, and were they exercise naive, everybody, or do you have exercise programs in the units already? Because I just wonder if some of your lack of effect might have been that these were not exercise naive people who had already been on programs. So that was my other question.
So although there were exercise programs which were running within the unit, the patients were exercise naive in terms of intradialytic cycling.
Okay, all right, okay.
Can I ask you a question from a cyclist perspective? I'm interested in the amount of aerobic dose you're sort of giving these patients. I know Chris Froome might cycle 400 watts. A keen amateur might do 300. A good Zwifter might do 200. My 10-year-old son does 100 watts for about an hour if he can. What were these patients doing whilst they were on dialysis? So is it in the region of the cycling you see on an exercise program, or was it substantially lower?
It was substantially lower, and we were looking at it really in terms of patients achieving either a calorific total or really looking to them trying to achieve more of a time commitment. Then the wattage that patients were able to achieve just varies so much depending on whether you've got a frail patient or a fitter patient. So yeah, I think that's where those measures have to be tailored to the population rather than the general population.
Sure. And I was struck by the point that you made about resistance training, and I'm just wondering whether or not when we've used accelerometers to measure physical activity amongst dialysis patients, we've noticed that the key predictor of poor physical activity has been, you know, skeletal muscle strength, not prior cardiovascular disease. Do you think we need to be fixing these people's muscles, their strength, before we start to try and improve their aerobic function? Might we be not seeing changes in quality of life because we're essentially providing them with improved aerobic health, where in actual fact it's skeletal muscle health which is limiting them most?
I think that's really interesting, and I think we need to look at progressive resistance training in much greater detail. It's quite difficult to deliver during intradialytic sessions, and I think, you know, the benefit of intradialytic cycling is that it's able to be delivered while people are visiting a dialysis unit 3 times a week, and that's always been the draw of it. There has been some contraptions, if I say contraptions, which have been done to try and deliver it, but I think the exercise physiologists among us would say that it's difficult to be able to deliver the dose of progressive resistance training during intradialytic during dialysis. However, I think that's something we need to look at off dialysis, so extradialytically.
And these quality of life questions, did they make, so sometimes cycling makes you feel fitter and makes you do more exercise between dialysis sessions. Were you able to measure at all whether or not this intervention not just felt that made them perceive that they got better, but actually exercised more? Did you put a Fitbit on everyone and see if it did more steps every day, or was that not part of the assessments?
So we did have some accelerometry data, which hasn't been reported in the primary manuscript, and we didn't find that there was a significant improvement of between session physical activity.
Right. Ken.
Any follow up there?
No, Ken, if you please far away.
Oh, no, it's great. One just general question I had like you to comment on is, you ran this program with physical therapy assistants, which I think is a really important thing to do, although be it maybe not practical for most clinics. So we get this question all the time. Dietitians, nurses, whoever, nephrologists email me or call me to ask me advice about how to set up a program. And many clinics try to run programs run by nurses, technicians, dietitians, whoever, whatever. I advise them it's very difficult to do that. I hate to say that to them, but based on my experience, based on what you just have gone through with where you have money to pay physical therapy assistants to run the program and still have kind of marginal benefits. What advice do you have for how would you respond to a nephrologist who calls you up to ask you how to start a program with their existing staff? It's a really challenging thing to answer because you don't want to be so negative, but you also recognize the practical, parts of it.
Yeah, and I think, what we realize is that it can't be an add-on to somebody's job because it's actually too big. It's too much of a commitment, a time commitment and an effort commitment to add it on to, a nursing job or, somebody else's job while they're coming in to maybe assess somebody's nutritional needs, unless they've got the scope within their job plan to do that. However, I guess my advice that I would give is that it's not just intradialytic cycling, and actually it's probably good to do some exercise counseling around what actually patients want to be doing. And it may mean that there are a small proportion of patients that are keen to do intradialytic cycling, and it might mean that you're using the other part of that time to encourage other types of activity in those patients.
That is the exact response that I usually provide, so I appreciate you saying that.
I agree as well. That is exactly it.
Yeah. Great.
Thank you.
There is just one question in the chat, just asking why did you analyze VO2 max in the patients who are quite deconditioned, and just wondering about the cost of that, if there was rationale for that. My understanding was that was partly how you actually prescribed the initial exercise intervention, but can you expand on that?
Yeah, it was. And also, we at the time, because if you think about when we set Pedal Up, the data from Kathy Sasima's study around, VO2 peak was quite strong. And, we actually at one point were looking at whether we would have that as the primary outcome, although we actually decided and, changed that to a patient reported outcome. But yes, you're quite right. We used it to prescribe the initial part of the intervention, but also just we thought it was an important secondary outcome. But it's a very good point because you can see from the data that we report that actually we had very low levels of VO2 peak, and actually we did have a very deconditioned group of patients. So it does highlight that.
Do I have time for one more question? Yeah, okay. I just wondering, I know you had no statistically significant differences in your secondary outcomes, but you also had less people actually attend the outcome assessments. So did you have power for those secondary outcomes to detect a difference in any of the secondary outcomes?
So we were powered to detect the VO2 peak because it's a similar number. but we actually didn't go any further. I don't think we were powered to detect any of the other secondary outcomes. So anything like mortality and SAE, well, you know, those.
And the physical function ones, like the timed up and go and things. The reason I'm asking, Sharlene, is just in a study that we did a while back, we also had no effect on PCS, no statistically significant difference, but we did find some physical function outcomes. And I just looked back and we actually had similar PCS scores between kind of 35 and 40. So, so I just wondered if maybe part of the problem with the secondary outcome differences was that maybe the power was just a little bit too low for some of the physical function. So.
Possibly, and I think that's something really good to, I'm going to take a look and drop you an email.
Yeah, thank you. Thanks, Sharlene. Congratulations on getting this done. What an effort. Yeah, what an effort.
Thank you.
Yes, thank you, Sharlene. It's fantastic to see randomized data. You commented before about observational data, and it's very nice to see sort of these more detailed causal assessments. And Jim, you've been doing something similar, but looking at people's outcomes in a slightly different way with a psycho-HD. Would you mind telling us all about that trial?
Yeah, I shall share my screen and you can tell me if you can see. Has that come through? You see that? Perfect. So they're my disclosures. Like Sharlene, nothing really relevant to this presentation. And I'm going to present some of the results from the CycleHD trial, also funded by the NIHR, but with some key differences. And Sharlene's outlined this really succinctly already, but I've got 2 slides just to think about why we should be exercising. And so this is the lens through which we were looking with the CycleHD trial, and it was more around cardiovascular outcomes. We know that cardiovascular disease is the principal cause of mortality in the dialysis population, and that is driven by non-traditional risk factors, which exercise intuitively has a significant ability to impact upon. So that's the first slide. And then the second slide, which actually, Will, you were referring to and we've talked about, and that is around muscle mass. And so these are cross-sectional MRI images from a study that we were doing in Leicester that just illustrates the point there. You can see on the left a healthy control, a cross-section of muscle at the thigh versus someone with CKD stage 4, and just looking at that level of sarcopenia and muscle wasting. And so initially we thought that would be, a key driver to cardiovascular risk, inflammation and sarcopenia. And perhaps we'll talk about that later. Okay, so like Sharlene, we wanted to kind of investigate whether intradialytic cycling would have a positive impact on cardiovascular health in patients on dialysis. And that's the CycleHD trial. And our primary hypothesis was whether or not 6 months of training would lead to a regression in LV mass in patients on dialysis, with some secondary outcomes, of course, around safety, around cardiac arrhythmias, and to a certain degree around quality of life. And I can't go on without saying this, but actually we talked about the quality of life tools, and our patients were so deconditioned, and Sharlene talked about how deconditioned our patients are. And you do have to wonder that in that moment where people start exercising when they're so deconditioned, whether or not that actually makes them feel good in that first moment, and whether 6 months is enough to really understand that. Okay, so a similar length of time, 6-month program of progressive cycling for at least 30 minutes was our intervention. We didn't base our prescription on VO2, but more on a perceived rating of exertion. We got people exercising so they felt somewhat, it felt somewhat hard, they were out of breath. And we adjusted that resistance over time to maintain that effort as patients started to become more conditioned. And I show this slide just because lots of people think that this is just an intervention for younger, fitter people. And I hope from here you can see that actually from some of our participants, that was very much not the case. So let's think about the results of the study, which were published earlier on this year. 130 prevalent patients, average age slightly younger perhaps than you might see on your units of around 57. And we did it in a cluster randomized fashion from 3 of our hemodialysis units. And we were looking at change in LV mass between baseline at 6 months between the 2 groups using a cardiac MRI. So this is a busy slide. I just want to pick out a few things. So we screened 315 patients and we consented 155. And it's worth just sort of pointing out from that actually a lot of the reasons that people didn't go on to consent to the trial was because they weren't eligible for an MRI scan. So actually, although Sharlene says it's not an intervention for everyone, we found that we actually consented a significant number that we approached for the study. And a lot of those that didn't, it wasn't the intervention that deterred them, but rather an MRI scan. And what you can also see here is that from the start to the finish, so 65 in each group from the start, 50 participants in each group completed the 6-month intervention. And again, a lot of those that dropped out, it was for reasons that they didn't want a repeat MRI scan, rather than the fact that they dropped out because of the intervention. We talked a bit about adherence already, but again, what I just want to highlight from these slides is we saw quite good adherence of all of the sessions of exercise that were offered across the 6 months to all of the participants. You can see it did tail off towards the end, but throughout the whole study, more than 2/3 of offered sessions were taken up by participants. And actually, when we look at the amount of time that people were taking part, it consistently remained above 30 minutes. So we saw a really good adherence to our intervention over that 6-month period. Okay, so let's get on to the money shot here. And that actually we saw a significant reduction in LV mass between groups over 6 months. In our controls, as you might expect with dialysis, that over 6 months, there was an increase in LV mass of around 1.5 grams. So as time went on, the LV mass went up. But in our exercising group, they saw a reduction in their LV mass of 10 grams. And the treatment effect was around 11 grams between the 2 groups. And that was highly statistically significant. So we've seen a reduction in LV mass as a result of that intervention over 6 months. And even on sensitivity analyses where we imputed for missing data and those few patients who dropped out, we still saw a significant effect that was statistically significant. Okay, so just talking about some of the secondary cardiac outcomes, also led to improvements in T1 mapping, pulse wave velocity. And I'm going to just talk about why that's important, because many people on the call may not be familiar with T1 mapping, which is a cardiac MR biomarker, an imaging biomarker of cardiac health. So effectively, T1 mapping on an MRI scan is about an increase in water. So if you've got an increased T1 time, there's more water hanging around. And what that means is that there is an increase in the interstitial space in the myocardium. And that increase in interstitial space, apart from potentially contributing to increase in LV mass, represents interstitial inflammation. And that's important because if we've got a therapy that can reduce LV mass and reduce interstitial inflammation, like cycling, for example, or exercise, then that potentially will reduce LV mass and improve cardiovascular health, of course. And we've published around the validity of that as a biomarker of inflammation and fibrosis. And so we saw improvements in that. We saw improvements potentially in interstitial inflammation. And you can see that there, the difference between the control and the exercises in global T1 times. And quickly, I want to talk about pulse wave velocity. A lot more of you will be familiar with this as a surrogate outcome, but essentially, as CKD progresses, especially those in end-stage kidney disease on dialysis, our arteries become more stiff. And as a result of that, that reflective pulse wave that comes back increases that effort of the myocardium and leads to left ventricular hypertrophy. And the result of that is you can see that in those patients with stiff arteries, with LVH, that reflective wave adds on to the pulse wave and makes cardiac effort much harder, which contributes to ventricular hypertrophy. And for those of you, we could debate this. I'm sure there might be some questions, but there's no doubt that there is certainly a train of thought that controlling left ventricular hypertrophy is a good surrogate for cardiovascular outcomes in people on dialysis. So again, both of those surrogate endpoints, those secondary outcomes, T1 times and pulse wave velocity, were significantly improved in the cycling group over 6 months. And you can see that there again for change in pulse wave velocity. A couple of other things, because it wouldn't be right in a talk where Sharlene is similarly talking around physical function. So we did see some improvements in walking tests. So there was an increase in distance walked. We did see an increase recorded on accelerometers of number of steps per day. You can see there was a significantly higher number of steps per day in the exercising group, an extra 730 steps. We weren't powered to detect a difference. There wasn't a statistically significant difference, but nevertheless, all of these signals were in the right direction, whether they were quality of life scores or field tests for physical activity. Just thinking about safety signals, none of the adverse events that were reported during the study were related to the cycling intervention. So just as was seen in the pedal trial, we really didn't see any signal of problems with safety as a result of the intervention. I'm just going to, and so the conclusion of the study there was very much that we see improvements in cardiovascular outcomes, it's safe and relatively well tolerated. Now, this is a little bit off-piste because this is a separate publication, but from the data in Cycle HD. So we had some additional funding from the NIHR to look at the cost effectiveness of our program. And we did this in quite a detailed way, actually. We went back and we looked at all of the hospital admissions between the two groups, all of the things around prescribing, any interaction with health services, be that primary care or admissions to secondary care. And we saw significant differences between the two. I'm not going to go into a lot of detail around that, but nevertheless, if you extrapolate out to 12 months, the cost effectiveness of the program, so that's the outlay of bikes, the outlay of staff, as Sharlene said, physical therapy assistants or physio assistants to staff the program, that actually there's a greater than 90% chance that running a program like this would be cost effective at 12 months. Okay, so a few conclusions. Our 6-month program of intradialytic exercise led to a reduction in LV mass and had other benefits in terms of cardiac adaptations. We saw good adherence to the program. There was a greater than 90% chance that a program of intradialytic cycling is going to be cost effective at 12 months based on our data. Having it as an option for people, and as Sharlene said, it's not going to be right for everybody, but for those who might see a benefit, I think it's absolutely right that we should be thinking, how can we offer that? It's recommended in clinical guidelines, but as we've alluded to already, implementation of that is going to be a challenge. So I'm going to stop sharing at that point.
Thank you very much, James. Similarly, I've seen this a couple times and it's always exciting, and congratulations on completing this. I think I'm going to start the discussion with one of my questions that has also come up in the Q&A, and just a reminder that there's also a Q&A section that you can ask questions for people who are attending the webinar. So adherence, it was very different between the two studies. And so maybe both of you, but initially a few questions for you, James. One, can you describe the run-in period and what exactly happened during the run-in period, and whether people were excluded during that time, and how that might have contributed to adherence, and why you think your adherence was higher?
So I'm going to answer that in reverse. So we'll talk about the run-in time. So effectively, we had a month's run-in time. People just got used to the equipment. They had a much kind of higher intensity level of supervision at that time. And we sort of set the resistance for them and really got them ready for their kind of 6-month program. And I guess my reflection on our adherence is that I was lucky enough to be also involved in the PEDAL study, and we were a recruiting site to the PEDAL study. And I guess that gave me an opportunity to kind of really reflect back on what were the differences between them. And I guess part of it is probably that they're research studies. You know, yes, we're trying to replicate real world practice, but they are research studies. And my reflection of PEDAL was that actually, unlike Cycle, it was smaller, it was in less centers, and we had people from our team who went every time, and they were really familiar with exercise. And so I think our threshold, when people said, I feel a bit breathless, I feel tired, we were saying, well, you're deconditioned and you're exercising, and that's completely normal. You just got to push on a little bit. And but I wonder with PEDAL, just reflecting, because sometimes some of the research nurses help to deliver some of the sessions, is that threshold to push people rather than to say, be nervous and stop people from doing the exercise. Maybe they were different. That's a personal reflection. But I guess in terms of why we perhaps saw a different level of adherence was really that we really had that level of one-to-one supervision, encouragement. And that's why I think the only way that exercise programs are going to work is if you, as Sharlene said, you've got to have dedicated people delivering it with experience in that area, so that patients feel reassured and comfortable, and staff are not burdened by the delivery of it. So I'm going to stop there, because I'm sure Charlene's got a reflection on that as well.
Yeah, so I think I think it's very interesting, but I think, PEDAL was very, very inclusive, and because it was a pragmatic, real world study, we really tried to keep that inclusion criteria very broad. And I think you can see from the baseline data that we had a lot of very deconditioned patients. And I think this is where, I think looking at the results from both of the studies, possibly in the Cycle study, you had a slightly higher functioning group of patients who chose to take part in that study. And I think it's important to realize that, those are the groups of people that we are probably trying to target with this type of intervention. And actually some other patients would possibly prefer to do other things. And if we'd had other things on offer and we'd had a choice, that if somebody didn't feel like they were very happy with doing cycling, and we had something else to offer them, we might have also been able to keep those people involved.
Yeah, and James, to your point, I think anecdotally in our clinical program, I definitely see, depending on who is the person in the unit, the kinesiologist in the unit, people will and will not exercise. It depends on the motivation that individual provides. So I think that is actually a very important component that sometimes you can't really control for in real life or in a study. So
yeah, I also think we have to remember these are both randomized controlled trials. So at the outset, when patients were approached, they were all willing to take part in an exercise program. And in that sense, they're not that different between the two studies. They're all individuals who consented to take part in an exercise program and were randomized at that point to one group or another. So there's absolutely no doubt, and Sharlene and I have kind of looked at the differences between our groups, but they are still the kind of people that we would approach to ask to take part in an exercise study. That's the nature of the trial. But there were definite differences in adherence to the intervention. And I think it would be a benefit to tease out those differences, because exactly as Sharlene said, you're not going to get a benefit unless you actually do it. We have to acknowledge that. I think that's really important to acknowledge.
One comment related to that, though, is that you guys, Sharlene, correct me if I'm wrong, but the way you guys measured, well, you measured adherence and compliance, and it was the adherence was based on if they, did everything exactly as you asked, and you also had that resistance training component to it, which is different. So that, the compliance, I think, was measured in the same way, but you also had this additional adherence measure, and I don't think you guys did, James, but so that's, I think that might be part of it. And also your intervention was a little bit, more involved because you had this other, the resistance training piece. So that just, I would want to throw it out there as that's possibly
That's very true, Ken.
At least part of it. Could I interject also one other, I put in the chat because there has been all these comments related to how we measure quality of life. And Jim, you had mentioned, the 6-month time period may not be appropriate for measuring this. And I'll just say in this paper that just came out yesterday, I don't expect a lot of people have seen it. I just caught it out of the corner of my eye when I was doing some searches. They actually developed an app to measure quality of life on they basically use every day. They give the patients access to this. And so their thought was that they were able to capture these improvements in quality of life in response to this different dialyzers they were using. Because they were measuring in real time as opposed to asking them 6 months later. And so I don't know much about this app. You can read the paper, but I think it's an interesting approach. I do think it's a new tool, at least a type of a tool that we might want to consider as opposed to these quality of life surveys that I think are just poor.
Yeah, and I guess I think I've mentioned this before, but I did the Couch to 5K app and at the start of lockdown as something to do when we could leave the house to do some exercise. And there's no doubt that I was deconditioned at that. And so, after about 3 or 4 months, I did not feel better, actually. I was sore and aching and, but sometimes we do things because we know they're good for us. We prescribe treatments because we know that they actually are good for our outcomes, but they don't always make us feel great to start with. That's an anecdote, but I think it's true. These are really deconditioned patients, and there has to also be an acknowledgement that they're going to feel aches and pains and feel that exercise might not actually make them feel great to start with, but cardiovascularly, it's good for them. And sometimes we perhaps need to encourage people to do things that they might not feel that benefit immediately, but we know that the long-term benefit is going to be there.
James, along those lines, I know in the cost effectiveness paper, you did measure EQ5D, and obviously you found a cost effectiveness benefit, but was there a difference between the groups when you looked at it just from the point of view of EQ5D scores?
There was, absolutely. It didn't reach statistical significance, but in the same way, we weren't powered to do that. And like the pedal trial, it was frustratingly close. I didn't show those data because they didn't reach statistical significance, but we did see improvements.
Yeah, I just want it, so it's kind of similar to pedal findings and it goes to your point that I think, and to add to that point, I think there's a lot of things that contribute to quality of life, even in PCS score, that may not be managed by exercise. For example, itch, or high fluid gains that aren't managed by exercise. And so I think the fact that also you didn't have statistical significance regardless of power or not, is actually supportive of that kind of hypothesis
that's
that
right.
there's more things going on. So
yeah, definitely.
Can I ask a couple of questions from a more naive perspective? Jim, you said the cost-effective analysis, nice, Clara brought them in. Did you see changes in hospitalization use? I didn't see that was stated in the slide. I was interested to see if you actually saw a reduction in use for cardiovascular admissions, or what was the cost effectiveness driven by?
It was driven by a reduction in hospital length of stay in those that had taken the exercise program. That's where it really was driven. We saw a significant reduction in hospital length of stay. Yeah.
And I'm sort of hearing that you think that the two trials have consistent results, and that they're compatible with each other. Can I ask you, maybe all of you could answer this question, if you had one single exercise intervention that you would apply universally to all dialysis patients and perhaps do another trial on, would it be cycling or would it be something else?
I'm sure we've all got our thoughts on that. I'm going to go first. I think it would not be exercise on dialysis, to be honest with you. I think it would be increasing physical activity and exercise outside of dialysis, and probably the most accessible thing for everyone is walking. Other people might disagree with that, but the flip side is we've got a captive audience that we can make use of, and so I'm still coming back. If it was the best thing would be more active all the time outside of the unit, but we've got patients we got access to, and I still think that's a really key time to kind of monopolize and use best.
Does anyone disagree with Jim, or is it just as much walking as you can outside of dialysis?
I don't disagree with Jim at all, because I think I think that's completely right. But I would say that I don't think I would ever recommend just one thing. And so you could put me on the spot and say you've got to recommend, and I wouldn't do, because I think actually the most important thing is going to be patient choice. And it really is about, we don't expect people in the general population to all do the same thing. So why would we expect that our dialysis patients would want to do that? So I think behavior change techniques being used, motivational interviewing, allowing patients to come up with what it is that they want to be able to do, I think is probably the most important thing, alongside any type of intervention.
So could you tell us what is the next big trial that's going on in exercise intervention, or that type of intervention in patients with end-stage kidney disease?
So I can't talk too much about it, but there is a trial which has just kicked off in Australia, and the protocol's just being finalised. I'm on the global steering committee for that, and that will come out in due course. And I think that will elucidate some of the things we've been talking about a little bit further.
Exciting. Well, I think we have to call time now on the e-seminar. Chapeau to you both, Sharlene and Jim, for completing trials, the blood, sweat and tears, and particularly sweat in this case, of delivering randomized trial. I can see there's thank yous from the audience. They're grateful. I'm also very grateful to Dr. Clara Bohm and Professor Ken Wilund for attending and supporting us with the discussion. It's been fascinating. Please do go check out the CKJ website. Sharlene's pedal baseline paper is there, available open access. Please check out CKJ website for other papers, including an editorial written by Jim on myocardial stunning and while cycling and dialysis. Please spend just a minute doing the Zoom poll at the end of this talk. We really appreciate your feedback, and it helps us keeping these seminars running. And then if you've got time, we'd really like to welcome you to join us again on Thursday at the end of October the 28th, when we're actually going to be discussing the post-transplant diabetes management using the latest agents, with a team from Barcelona and expert insight from Professor Shankar Navanathan. So we look forward to seeing you then, and thank you to Sharlene, Jim, Ken and Clara.